So today, we're going to talk about a video that's been very, very long requested. It is the ACLS, how to pass it like a boss. So stay tuned. So I want to preface this video by saying we're going to kind of go over a little bit of your BLS as well as your ACLS. I'm not going to make a separate video for BLS just simply because of the fact that a lot of the information that's covered in your BLS is also really covered in your ACLS. So I'm kind of combining those together. So if you listen to the course, I'm going to touch on key points. I'm not going to go into a full depth conversation regarding ACLS and BLS. I'm really going to cover what's important for you to know for your mega code as well as what you need to know for your tests. So to begin with, we're going to start off with our basic life support information. So what is the first thing that you're going to do in regards to your ACLS as well as your BLS? You're going to check for responsiveness of the patient. So you're going to tap the patient, hey, are you okay? If they don't answer you, you're going to shout for help. You want to immediately activate the emergency response system. Let that person know that's activating it, or if there's someone else there, please find me an AED or defibrillator. Some people know them a little bit differently. Some people don't know what an AED is. Step 3, you want to check for breathing and pulse. If there is no pulse and no breathing, you're going to begin CPR immediately. But the one top key thing that you need to know, and what will probably be on your test as well as your mega code, is you want to check for breathing and pulse no more than 10 seconds. 10 seconds at the max, start CPR. If a pulse is present, you can start rescue breathing. If somebody's kind of just gasping for air, not agonal gasp, but just kind of unconscious, but they have a pulse, you want to just start rescue breaths, make sure that oxygenation is getting to the brain. When you're doing compressions, the main number one thing, red, you see it in red, is you need to do 100 to 120 chest compressions per minute. That is ACLS guidelines as well as BLS guidelines. Respirations, 1 every 5 to 6 seconds. You do not want to do more than that because you can actually hyperventilate the patient. So when you begin your mega code, you're going to follow a very detailed plan of how you're going to assess and treat these patients. So you're always going to start out with your basic BLS, which we just covered. Then you're going to move on to your primary survey, which actually has a very good mnemonic. It's A, B, C, D, E, your airway, your breathing, your circulation, your disability, and your exposure, all of which we'll cover, don't worry. And then you've got your secondary survey. We're going to cover that at the end of the primary survey. So to begin, we're going to start with our A, our airway. You're going to maintain an airway patency in unconscious patients, whether that is putting in an advanced airway, whether it is bagging until you can get an advanced airway. We need to make sure that the airway is patent. We need to confirm that our CPR, our ventilations are adequate. So what does that mean? We're making sure that we're pushing 100 to 120 compressions per minute, and that we're giving one breath every 5 to 6 seconds. Something very big you need to know when you're doing your mega code is you want to secure the device. You want to make sure that once a airway is placed, that device is secured on that patient so that it is not moving. Those are very important things that you need to know for your mega code. You want to monitor the airway placement. How do you do that? A continuous quantitative waveform capnography. So there's a couple different things that is achieved by. There's a little device that actually sits on the bag that'll change colors if there is positive CO2 moving in and out of the patient. There is also a machine that you can hook the patient up to that'll actually give you information regarding their capnography, where they are at in their carbon dioxide, their CO2, usually between 35 to 45 is what is achievable in regards to a stable patient. However, if your patient is not stable or they've been in cardiac arrest for a period of time, obviously those numbers are going to be a little bit different. So moving on in our primary survey, we're going to go on to breathing. You're going to give supplemental oxygen as needed, really 100% oxygenation for those that are in arrest. And you want to titrate the oxygen for stable patients. If a patient is stable, they have a pulse, they're breathing, but their oxygenation is a little bit low, obviously you want to give them oxygen and just titrate it until you reach what you need to reach, usually equal to or greater than 94% oxygenation. You want to avoid that excessive ventilation that we talked about earlier because that's no good to anybody. And then another important thing that you need to know that's very important is agonal gas are not considered normal breathing. It's actually one of the first signs of cardiac arrest. So if somebody is having agonal gas, then you need to start CPR immediately. Do not wait. So for your circulation, we're going to continuously monitor CPR quality. During this time, we want to make sure that we're minimizing interruptions and checking for the pulse no more than 10 seconds. 10 seconds seems to be a big number that is on ACLS, and that is a good thing to know. So make sure that you're minimizing those interruptions and that you're checking for that pulse no more than 10 seconds. If the person who is performing the CPR is not providing effective chest compressions, it is okay to give positive constructive criticism or feedback to that person. Hey, I noticed that you're slowing down a little bit. Do you need a break? Do you need to switch out, or can you keep up? It's just that way we're treating the patient effectively while also maintaining a good team dynamic, which we'll talk about a little bit later. We want to make sure that we're attaching that monitor, defibrillator, AED, because we want to know what's going on. Is our chest compressions effective? Do they have a heart rhythm? Do they have a heart rate potentially? So those are things that we need to monitor. The first thing when you are in the field, and this is important because this will come back to you, is you want to make sure that when you have the AED present, the very first thing you do before you attach pads, before anything else, is turning it on. Trust me, you need to know this. This is very important. As soon as you get it, before anything else, you turn it on. Then you follow the prompts. The AED will prompt you on what to do once it is on. You want to obtain that IV and IO. You need to start that immediately. That way we can start getting those medications on board and start getting some fluid pumped into these patients. Like I said, give the appropriate medications based on what the patient is presenting with. We want to administer those IV-IO fluids, start getting some more of that vasculature moving, and then we want to check their blood glucose. Blood glucose, a lot of times when people are unconscious, is because, their blood sugar is low, and those are things that you have to remedy to fix the underlying problem. You also want to check their temperature. I can't tell you how many people in Megacode don't check temperature, and it's one of the main things that they tell you to check. So if anything that you remember from this course when you're doing your Megacode is you want to check that temperature. And lastly, you want to check the capillary refill. You want to make sure that they're perfusing appropriately, no more than 3 seconds. And another thing as well is regarding blood pressure. Blood pressure should always be at a minimum of 90 millimeters of mercury. That is the standard in regards to post-resuscitation efforts as well as, during resuscitation. So make sure that is a big key thing that will most likely be on your test. Wink, wink. You want to make sure that blood pressure is a minimum of 90 systolic. So moving on into the D part of our A, B, C, D, E. So we've got disability. What exactly does that mean? We're checking for neurological status. We're making sure that we look at those pupils. We're making sure that they're dilated or they're fixed. We need to know those things. Those things ultimately tell us how the brain is perfusing. Any loss of consciousness. Those are kind of things, I know it sounds silly that you're talking about it now. The patient's unconscious. You pretty much figured that out during your BLS. However, when you're doing Megacode, they want to hear that from you. AVPU is also another thing. They want to know what the AVPU is. So what does that mean? It's AVPU. So they all stand for something different. A is the patient alert, awake. With it, you wouldn't be doing chest compressions then, would you? V is the patient responding to verbal stimuli. Can you talk to them and then they answer back to you, having to be prompted by that verbal stimuli? Is the patient only responsive to painful stimuli? Do you have to, chest rub them or chest sternal rub them to make sure that they are awake and that they can answer you? That would be the P. They're only responsive to the painful stimuli. And then lastly, of course, U is the patient completely unresponsive, unconscious. You're doing CPR. Most of your cardiac patients are obviously going to fall under the U. So those are also very important things to know when you're doing your Megacode. So lastly, in the A, B, C, D, E, we're going to talk about E. That is your exposure. So you want to remove those clothing. You want to assess for obvious signs of trauma. Is there bleeding? Are there any markings? Do they have a medical alert bracelet? You really want to take a good look at that patient to see what potentially is causing them to be in cardiac arrest. So now we're coming into our secondary survey. This is where we start to kind of pick up the pieces and figure out what's going on. And what's really great is they have a very good mnemonic, again, is SAMPLE. SAMPLE stands for signs and symptoms. What was going on when this happened? What were the signs and symptoms that led up to this? Allergies, are they allergic to any medications? Medications, have they taken any medications before they came in? Did they take any extra doses of something? Did they miss a dose and then potentially overdose? We need to know those things. Past medical history. You know, sometimes you're going to have a patient that's completely healthy and this just happens to and they have nothing. But a lot of times you're going to have patients that have a comorbidities of everything. And those are things that you need to know so that you can treat the patient appropriately. Their last meals and liquids consumed. That's very good to know in case there's any surgery or anything else that needs to take place. And then events. What led up to this? What happened? Talk to me about it. I know it sounds silly that we're not getting that information initially when we have a person that's in cardiac arrest or needing advanced life support. However, this is really where you want to get the details and figure out what's going on. And the last part of our secondary survey is we want to treat what is actually causing the problem. So we're going to go back to our H's and our T's, being hypovolemia, hypoxia, hydrogen ions, hypo or hyperkalemia, hypothermia, tension pneumothorax, tamponade, toxins, and a thrombosis of either the coronary or pulmonary kind. We want to eliminate what is not causing the problem so that we can get to what is and treat it effectively. So starting off with rhythms that you need to know. One of the very important rhythms that you need to know is ventricular fibrillation or pulseless ventricular tachycardia. This is something that usually shows up on Megacode, and it's a good thing to know, that way you're prepared. So is ventricular fibrillation or pulseless VTAC something that is important and shockable? Yes, it is a shockable rhythm. Yes, it is important. How do we treat it outside of CPR? We start by medications. The first medication that we give is epinephrine 1 milligram every 3 to 5 minutes. Second line medication is your amiodarone IV, or you can also give that dose IO. That is 300 milligram bolus to begin with, and then 150 milligrams each consecutive dose. Make sure that you are well aware of how this kind of plays out. So you're doing 2 minutes of CPR, and then we're checking for a pulse. We're looking at the monitor. We're seeing if the monitor is giving us a shockable rhythm. We shock and we continue CPR immediately. Then we start giving medications. It could be a little bit different in regards to where you are from regarding your facility, but for ACLS purposes, just make sure that you understand how that train of events occurs and then how you need to treat based on the rhythm. So moving on to another rhythm is a systole or pulseless electrical activity. What does that mean? Pulseless electrical activity means that the patient has no pulse, however the monitor is still showing that the patient does have a pulse or some kind of organized rhythm. So in this situation, what do we do? Is it a shockable rhythm? No, we don't shock these rhythms because again, there is no rhythm. What is our first line medication treatment? Usually epinephrine 1 milligram every 3 to 5 minutes, and we continue CPR. Moving on to our bradycardic patients. So if you have a stable patient that's able to talk to you and is bradycardic, meaning that their heart rate is less than 60, then for these patients, we usually just monitor and observe. Every facility is going to be a little bit different, but for ACLS guidelines, that's really what it's all about. If they're stable, then we just monitor and observe them. However, in contrast, if they're not stable, we treat them immediately. We do not hold back. We do not wait. So what do we treat them with? Well, usually medications. So we start with atropine. Atropine, we give 0.5 milligrams bolus every 3 to 5 minutes. We max out at 3 milligrams. Once you've reached 3 milligrams, it's obviously not going to be effective, and we move on to something else. And again, this is based on facilities, so sometimes they'll stop way before that. But for this purposes, our max is 3. Dopamine infusion is another big one. We give that IV. It's usually 2 to 20 micrograms per kilogram per minute based on a lot of variable factors. Just make sure that you listen to your physician and follow your orders and treat that bradycardia. Moving on to our tachycardia considerations for patients, 150 beats per minute equal to or above that. So for our stable patients, any stable patient that we have, we're always going to do a 12-lead EKG on all stable patients. And I'm going to repeat that because that's important. Any stable patient that we have, we're going to repeat a 12-lead EKG. We're going to ask these patients that are stable to vagal maneuver. They're going to, clench down and hold their breath and try to vagal out of those rhythms. If that doesn't work, then we move on to adenosine. We're going to give 6 milligrams rapid IV push. We're going to monitor the patient. There's going to be a brief period of time that their heart kind of stops and then restarts itself. And hopefully that takes care of the problem. Now for unstable patients, obviously they can't follow commands. They can't do those things. So what do? We do synchronized cardioversion. Some facilities it's going to be a little bit different, but for the purposes of ACLS, that is the number one thing that we're going to do for unstable patients that are in these tachycardias. If it is a regular narrow complex, you might want to consider adenosine. Again, that's up to the facility, but that's just also another good rule to follow. Torsades de pointes, which is a ventricular tachycardia rhythm. It kind of looks like it's doing this on the monitor. You're going to give magnesium sulfate. That's kind of like the bottom line treatment in regards to that, and that's probably potentially going to be on that test. So after our CPR efforts, if we do achieve a return of spontaneous circulation, meaning ROSC, you hear that a lot with these post-resuscitation patients, then we kind of follow a different algorithm in regards to how we maintain these patients. So of course, like we spoke about before, we want to maintain an oxygen saturation of 94% or better. We're going to treat their hypotension. Again, their systolic blood pressure needs to be greater than 90%. That is the minimum in regards to what they find as an effective perfusion for systolic blood pressure. 12-lead EKGs, all of our stable patients, once they're stable, they still might be critical but stable, we do 12-lead EKGs. And then immediately we start temperature therapy. Now again, facilities are different, but for the purposes of ACLS, we start temperature therapy immediately. And we continue rechecking that therapy every 24 hours for its effectiveness. So a good rule to follow is you want to know your rhythms. So in order to know your rhythms, you need to know what they look like. My suggestion for you to review is to review all your blocks, your first degree blocks, your second degree type 1, type 2. Also look at your complete heart blocks. They may or may not show up, but it's also a good thing to know because they are quite different. You want to know your ventricular tachycardias. You want to know your ventricular fibrillations. Know those asystolies. Know what that pulseless electricity activity is. Make sure you know that there is no pulse, but they're showing a rhythm. That's basically the initial things that you need to know that could potentially be in your megacode as well as your test. So I want to talk a little bit regarding dynamic roles. These are the roles that everybody plays during a procedure, whether that be cardiac arrest or any other kind of procedure that happens. Everybody has an assigned role and everybody is knowledgeable in that role. I'm not going to go too much into everything specifically regarding dynamic roles, but what's important. So what is important? If a person is assigned a role that they are not knowledgeable at, or it is outside of their scope of practice, that person needs to speak up and tell them, I'm uncomfortable with that role, or I don't know that role, or that is outside of my scope of practice. That person is not allowed to ask another individual to do that role. It needs to be whoever the team leader is. That way the team leader is aware of who is doing roles during these processes. Another thing that is extremely important is closed-loop communication. You want to repeat whatever the person has said and advise them when something is done. So if a doctor tells you, give epinephrine 1 milligram, all right, I'm going to give epinephrine 1 milligram, pulling it up now. I have epinephrine 1 milligram ready to go. Once the doctor or team leader informs you, okay, give it, you're going to put it in there and you're going to push. I am giving epinephrine 1 milligram now. So that way everybody knows. It's a very closed loop. There is no questions that needs to be answered. It is what you're doing when you're doing it. So those are really important things to know regarding your dynamic team roles. And lastly, we're going to just touch a little bit on stroke guidelines. Your book has a very good outline in regards to what you need to know and what steps you need to follow. Things that are really big in regards to stroke guidelines is giving fibrillation therapy immediately as long as there are no contraindications. Every facility is different in regards to the contraindications. I know that there's also a time period in which you can give those medications. They're all different. Just make sure that you follow facility guidelines. And the last thing is you want to get them into a CT scan without contrast immediately. The quicker that they're in there, that we can find out if it is an ischemic stroke or a hemorrhagic stroke, the quicker we can treat the patient. I hope this video was very helpful to you. It was very helpful for me when I started taking my ACLS renewal. If you have any comments or any questions regarding anything that I covered today, I would love for you to leave them down below. I love answering them. Make sure that you check out my PALS video in case you're renewing that anytime soon. I'm going to go ahead and leave a link up here in the corner for you. I'm going to post also a blog post regarding this ACLS, so check out my website. There's a lot more information over there.